start. Yes.
Hello, everyone. Thank you for joining us today. It's my great pleasure to introduce Dr. Mina, uh, a highly experienced professional. Please give me a welcome.
Thank you, James. Thank you. Thank you so much, ladies and gentlemen, for being here with us today. I'm Dr. Mina Mohab, endodontist from Egypt, and today I'm going to share my clinical experience with you about bioceramics in daily practice. We are going to talk about root ST and root PT, different clinical applications. root ST is a bioceramic sealer that comes in a syringe form, while root PT is a pre-mixed bioceramic putty that comes in a capsule form. Composition for both are composed of calcium aluminosilicate compound as a bioactive component, and zirconium oxide as a radiopacifier, which does not cause any discoloration, and a thickening agent. Uses, of course, root ST is a bioceramic sealer, is used as a permanent root canal filling material in conjunction with gutta-percha, while root PT is a bioceramic putty, is used as in vital bulb therapy, either direct or indirect bulb capping, partial and complete bulbotomy, regeneration, revascularization, epixification procedure, as a root canal, as a retrofilling material in apical surgery, lateral and furcal perforation repair, internal and external root resorption, and in epixification procedure as a putty plug. Of course, nowadays there are so many studies that support the use of bioceramics. If anyone is interested to search for the titles. And here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealers. In this study, they classified the hydraulic cements according to the percentage of the calcium silicate in the composition, which is very important while you purchase any bioceramic sealer to search for such percentage. They classified the hydraulic cement according to the calcium silicate content, and they classify it as follow: low charge, which is lower than 20% calcium silicate content; medium charge, which is higher than 20 and lower than 40; higher charge, which is equal or higher than 40%. According to VERICOM's material safety data sheet, where root ST contains from 50 to 60% of calcium silicate content, which is considered the highest PC sealer worldwide. What is hydraulics? This is our basic technique. Hydraulics is the injection of the bioceramic sealer into the root canal system, then applying your master cone gutta-percha to the full working length, which act as a piston that pushes the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. Here is a quick video that shows the material consistency and flowability while injected in a plastic block where 3 lateral canals were simulated. Look at the flowability and the consistency of the sealer. The sealer flows without adding any gutta-percha yet. After that, you will put your master cone to the full working length. The master cone also acts as a bus for retreatment in case of failure. After that, you sear off the gutta-percha at the orifice level and do some coronal compaction, and you're done. Just take about 10 seconds. All exits were filled. Okay. Here are the examples. Here is a lateral canal filled related to upper lateral incisor. Here is a lateral canal filled related to upper canine. Here are 2 lateral exits were filled related to lower first premolar. 2 lateral canals are filled related to upper second premolar. An isthmus area filled related to upper first premolar. Here is a lateral canal and apical delta related to lower second molar. Here is a lateral canal filled related to lower first molar. The 3-year recall after crown placement, the lateral canal is still filled with the sealer. The sealer did not wash out, did not resorb by time, which is very important. Here is a lateral canal filled related to the mesial root, and an isthmus area related also to the mesial root was filled with the sealer. The 5-month recall shows healing, and the lateral canal is still filled with the sealer. Here are 3 lateral canals are filled related to the distal root of lower first molar. Here's a lateral canal filled related to upper first molar with 4 roots related to the palatal canal. In this case, I wasn't able to achieve patency. This is a type C lower second molar. I wasn't able to achieve patency, so I injected the sealer and added tapered auxiliaries. Till this, no any exits are filled. After I seared off the cataperca and I do some coronal compaction, as you see, 2 lateral exits were filled with the sealer. And here is the 3 months recall after indirect composite restoration. The sealer still exists. In this case also, I wasn't able to achieve patency in the distal root. After I injected the sealer, seared off the cataperca, I got a tortuous lateral exit that was filled with the sealer, which was nearly impossible to be negotiated with hand files. No file can go through this area. Again, in this case also, I wasn't able to achieve patency in the distal root. After I injected the sealer, I got an abrupt 90-degree lateral exit that was filled with the sealer. Files can go through there. Here's the lateral canal filled related to the palatal and 2 lateral exits related to the mesiobuccal and distobuccal root. Here's the 3rd exit for the distal root. Loop filled related to the mesiobuccal root of upper first molar. Here is a variety of upper central incisors. Upper central incisors has more than 40% incidence of accessory canal. This is a variety for upper central incisors. Root ST will help you achieve the optimum apical seal in almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter, extremely curved roots, multi-planar curvature, S-shaped curvature, in cases of conservative shaping, teeth with external root resorption, compromised roots for strengthening, large periapical lesions as it promotes healing, and in cases of limited accessibility and limited mouth opening. This is a multi-planar curvature combined by conservative shaping related to upper first molar. This also multi-planar curvature combined by conservative shaping related to lower second molar. Multi-planar curvature combined by conservative shaping related to the mesial root of lower second molar. In case of long roots, this canine was 32 millimeter length. This case also long and curved roots. PC sealer will help you a lot in such case scenario. Separated file retrieval. When we retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics, as bioceramics bond to dentin and act as a mono block, which makes root more strengthening. In this case, after we retrieve the separated file, we compensated the lost dentin using bioceramics, and here is the 1-year recall, shows healing. Here also, after we retrieve the separated file, we compensated the lost dentin using bioceramics. As you see, the BC sealer flows through a furcal canal related to the furcal radiolucency, and this is 1 month recall after crown placement. This case has a different scenario. After I retrieved the separated file, the canals were oozing exudate, and I had to finish in 1 single visit. So I injected the sealer and finished this case. Look at the size of the radiolucency. The size is huge. It's a large radiolucency. Here is the 8 months recall, shows complete healing, and the sealer is still the same, did not washed out, did not resorb, despite the exudates that exist in the canal, which is a very, very tough test for any bioceramic sealer to withstand such tough circumstances. The sealer can be easily washed out before its final setting, as it takes about 2.5 hours to set. But thanks to the quality and the high percentage of the calcium silicates that allows the sealer to set without being washed out. Here is also after we retrieved the separated file, we compensated the lost dentin using bioceramics. This is a treatment case that went from simple to very difficult. Unfortunately, during getapercha removal, I separated 4 instruments in the mesiolingual canal, and 1 instrument goes beyond the distal apical foramen. I managed to retrieve all 5 instruments and finish the case, and here is a quick video that shows the procedure. Sorry. Thank you. This is the instrument number 1, the ultrasonic tip. This is the second fragment was inside the gutta-percha, using a wired loop device to retrieve here is a fragment. It's a treatment file. This is the file that was beyond the distal apical foramen, the XP endoshaper. This is file number 3. And here are files number 4 and 5. In cases of limited accessibility and limited mouse opening, this is a tough curved wisdom. This is another wisdom with anastomosis in the mesial and distal root. Healing of a large lesion. The X-ray on the right is the 2-year recall, shows complete healing. Look at the size of the radiolucency. This is also a 3-month recall. The X-ray on the right shows significant reduction in radiolucency size. This is the 1-year recall, shows complete healing, and the sealer did not prevent any healing. It promotes the healing as it's an orthopedic bone cement in its origin. Healing of a large lesion, look at the radiolucency as a distal root, it's healed. This is also healing despite there is a fragment that's beyond the mesial root, but healing occurred after 8 months. This is a 4-month recall. The X-ray on the right shows complete healing, and the lateral canal is still filled with the sealer. Again, this is a lower wisdom after we did retreatment. This is a furcal or a lateral canal that causes the lesion. As you see, it's filled with the sealer. This is the furcal bone. It's completely formed and completely healed. After 8 months, the furcal bone regenerated again. Again, after 1.5-year recall, it shows healing. Anyone here practicing vital bulb therapy? Raise your hand, please. Just one. That's unfortunate. 2, 3. Okay. Please pay attention to this part. After this part, you will reduce your root canal treatment cases to 30%. About 70% of your root canal treatment cases will shift to vital bulb therapy cases. So please pay attention. American Association of Endodontists position statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from trauma, caries, or restorative procedure. Vital bulb therapy procedures have traditionally included direct or indirect pulp capping and partial and complete pulpotomy. Number 1, diagnostic consideration for vital bulb therapy. You should have sound diagnosis. The current AE diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible bulbites, or irreversible bulbites. Number 2, caries management, complete caries removal. Any residual caries left behind will affect the prognosis, so remove all the decay. Number 3, use of sodium hypochlorite. Sodium hypochlorite is used in disinfection and hemostasis. Hemostasis can be achieved within 5 to 10 minutes, either via direct passive irrigation or on a sodium hypochlorite-soaked cotton pellet. Number 4, use of contemporary materials, which is calcium silicate cements or bioceramics, has improved barrier quality than calcium hydroxide. Immediate placement of a permanent restorative material. The advantages of immediate restoration includes the prevention of the micro leakage, protection of the biomaterial layer, reduction of the post-operative sensitivity and thermal conductivity. You will do all 5 steps in one single visit. The primary goal of vital bulb therapy is the creation of optimal conditions for bulb tissue repair and preservation. This paragraph is very important. A pre-treatment diagnosis of irreversible bulbites is not necessarily an indication for pulpectomy, as more conservative treatment could be considered. This means that you can do pulpotomy in cases with irreversible bulbites. What would be different clinical applications? This is a direct pulp capping for upper second premolar, exposure site capped with putty, immediate post-restoration, immediate post-X-ray, all in one single visit. Direct pulp capping for upper first molar, exposure site capped with putty, immediate post-restoration, immediate post-X-ray. This is a 2-year recall. The tooth was completely asymptomatic. Response normally to cold with no any radiographic finding. This is a successful vital bulb therapy case. Look at this case. We did direct pulp capping for the lower first molar. The X-ray on the right is a 4-year recall. Look, the bulb horn is still intact, or return it back again to be intact. Look at here, the body material inside here after repair occurred. Here also a 1-year recall for direct pulp capping. There is a barrier was formed. Tooth was completely asymptomatic also, and the barrier was formed. Direct pulp capping for lower second premolar. Direct pulp capping for upper first molar, and here is the 3-year recall. The tooth was completely asymptomatic, and the barrier was formed. Direct pulp capping in the aesthetic zone. This is direct pulp capping in upper lateral incisor. This is a direct pulp capping for upper central incisor. The X-ray on the right is 1-year recall, shows narrowing in the bulb chamber indicating barrier formation. And this is 1-year recall clinical image. By the way, there is no discoloration occurred in the central. We're gonna know why. This is a trauma case for a 9-year-old girl. She came like this, and I did pulpotomy. As you see, there is an open apex for the post-centrals. This is 9 months recall. Shows complete maturation of post-centrals. And this is 9 months recall for the centrals. There is no discoloration occurred in both centrals, so you are free to use this material in the aesthetic zone with no fear of discoloration, unlike most MTA brands that causes massive discoloration. Even the white, the gray 100% will do discoloration, but the white, most of them will cause massive discoloration. But putty will not make such massive discoloration. This is also a direct pulp capping for lower second molar. This is a 3-year recall showing a barrier formation. The red arrow pointing at the barrier that was formed after 3 years. This is also direct pulp capping for lower first molar. The X-ray on the right is 1.5-year recall. The X-ray on the left, 1.5. The X-ray on the right is 4-year recall, shows barrier formation. Okay. Here is a 50-year-old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be your treatment plan here, knowing that the first molar was completely asymptomatic? What will you do in such case scenario? Simply, I did root canal treatment to the lower second molar as the bulb was inflamed and has to be removed. While I did direct pulp capping to the lower first molar as the bulb was healthy and could be kept alive. But a meticulous preoperative X-ray analysis has to be taken care to avoid exposure of the projected distal bulb. So you need to tilt your hand a little to address the carious site without exposing the whole distal bulb. So I won't be able to cap this whole area. I will shift to root canal treatment. This is a 1-year recall. Both teeth are completely asymptomatic. Both are with no any radiographic finding. The first molar responds normally to cold. This is the 2-year recall, the same as 1-year recall, plus a barrier was formed. Look at the barrier. This is the barrier that was formed. Here is a red arrow pointing at the barrier. Direct pulp capping for lower first molar. Partial pulpotomy for upper first premolar. Partial pulpotomy for lower first premolar. Here is the 1-year recall. Complete pulpotomy for upper first premolar. Complete pulpotomy for upper second premolar. Partial pulpotomy for upper first molar. Here is the 6 months recall. Partial pulpotomy for upper first molar. Partial pulpotomy for upper first molar. It's a repeatable and reproducible procedure. Complete pulpotomy for upper first molar. Partial pulpotomy in such deep caries. Look at the margin. Complete pulpotomy for upper first molar. Even in fractured cusp, this is a fractured mesolingual cusp, as you see. Even with such a fracture, exposure occurred, so I did complete pulpotomy after I built the fractured wall, fractured cusp, and we did complete pulpotomy, and the tooth survived vital. Starting from this case, the diagnosis is irreversible bulbitis. Look at the dark red profuse bleeding that came out upon accessing the tooth. After controlling the bleeding and removal all the inflamed coronal bulb tissue, we had a perfectly homogeneous, well-attached bulb tissue to the canal wall. We can do complete pulpotomy. Same scenario for lower first molar, same scenario for lower first molar. Even in bulb stone, this is a case with bulb stone, as you see, after we remove the stone, controlling the bleeding, checking the attachment, we were able to do complete pulpotomy. This case we did partial pulpotomy. You can also do partial pulpotomy in cases with irreversible bulbitis. Complete pulpotomy for lower first molar, lower second molar. Complete pulpotomy for upper first premolar. And this is what I do in cases of irreversible bulbitis. This is our putty material, just adapted with, packet with Bond brush. You don't need any expensive carrier. Just take a suitable increment. You can add more increment, just adapted using a Bond brush, adhesive brush. Moisten with sodium hypochlorite to initiate its second setting reaction. After that, you remove the excess using another Bond brush. Sharp excavator. Then put any liner, any light cured liner to protect the material. After that, you can remove more excess to enhance the bonding. After that, you can do your etching and rinsing, then bonding, then your final restoration in the same visit. It's very important to do your final restoration in the same visit to avoid leakage. Okay. Root canal treatment and vital bulb therapy in the same tooth, in the same case. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Let's find out. Here's a 9-year-old boy who came complaining severe pain that awakes related to his lower first molar. Upon taking a radiograph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. The root was not fully formed yet. Upon exposure, dark red profuse bleeding with little amount of pus came out. Upon accessing the tooth, dark red profuse bleeding came out. The image on the right is after trials to control the bleeding. The image on the left told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I did cap the distal bulb and I did root canal treatment to the mesial root. Here is a confit X-ray. Here is immediate post-obturation and capping using post root ST and root PT. The X-ray on the left is 18 days recall. The X-ray on the right is 1 month recall after a stainless steel crown placement. Both are completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. And here is the 14 months recall, shows complete maturation of the distal root. This means that the distal bulb stayed alive and continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious exposure, retrospective study. Success of direct pulp capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with pulps exposed during carious tissue removal. 1 year follow-up randomized controlled trial, Journal of Endodontics 2019. Conclusion: teeth with carious pulp exposures and reversible bulbites can be treated successfully with direct pulp capping. MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and the meta-analysis, Journal of Endodontics 2015. Direct pulp capping with calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less pulpal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, a novel pulp capping agent. The pre-mixed bioceramic materials possesses favorable results and the also properties comparable to the currently recommended material for pulp capping MTA. The results are comparable or even superior. Pulpotomy of symptomatic permanent teeth with carious exposure using mineral oxide aggregate. Pulpotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Success of coronal pulpotomy in permanent teeth with irreversible bulbites, an evidence-based review. Coronal pulpotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients in teeth with irreversible bulbites as a substitute to root canal therapy. Vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbites. Reports with long-term controls. Vital bulb therapy with partial or total pulpotomy using bioceramics under aseptic conditions is a viable treatment that will have long-term success in permanent teeth with irreversible bulbites when indicated correctly. Australia Dental Journal, this was in 2023. Vital bulb therapy for permanent teeth with diagnosis of irreversible bulbites, biological basis and outcome. From a bulb biology perspective and based on data from clinical trials, partial and full pulpotomy using calcium silicate cements are successful treatment modalities for teeth with carious pulp exposure and symptoms indicative of irreversible bulbites. Look how many teeth were saved using our procedure, vital bulb therapy. It's very viable and efficient. Remember, the best root canal treatment is the one you can avoid. And the best obturation material is what God's created, which is the dental bulb. Or root PT as a root canal filling material. You can do also complete root canal filling, this case with irreversible, with apical periodontitis. The distal root was filled using root PT. I did this case 5 years ago. 2 years after, the patient came complaining severe pain related to the tooth. Upon taking a radiograph, I found a radiolucency related to the distal root only. So I retreated the distal root only and filled using root PT. 2 days after, the patient reported completely asymptomatic. Here I did selective root retreatment. And here is the clinical research that supports the procedure. Selective root retreatment, a novel approach. This is a trauma case for upper central incisor, where I filled the whole root canal system using root PT. This is also another trauma case where I filled the whole root canal system using root PT. You can do only apical plug, but I filled the whole system using root PT. This is a massive destruction for upper central incisor where I did apical plug, then I put 2 fiber posts, and I did completed the restoration. This is also an open apex related to the distal root of lower second molar with overextended getaperca. After I removed the getaperca, I filled the distal root using root PT. This also, we did complete root canal system obturation using root PT, and that's what I do in apexification procedure using just simple tools, hand debugger, paper point, getaperca points. This is a paper point for packing the body material, no need for expensive carriers. This is a hand debugger just gentle tapping on the material. And that's it, you are done. Extremely curved and long roots upper second molar. This is a case of massive curvature related to upper second molar. This is a master apical file. Of course, the most efficient and easy obturation technique is the hydraulics. You inject your PC sealer, put your master cones to the full working length, and you're done. This is another X-ray view. Bulb stone and multiple radiolucency management with 3, 6, 10, and 24 months recall shows healing, and 1.5 3-year recall for direct bulb capping. If you remember this case, we did direct bulb capping for the lower second premolar. Unfortunately, there were a hole in the crown of the lower first molar, so it was leaking food, led to caries, hence bulb necrosis and apical periodontitis. After I removed the crown, I found a bulb stone blocking the canal entrance, and here is the bulb stone clinically. We did root canal treatment, and here is the immediate post-obturation. The X-ray on the right is 3 months recall, shows significant reduction in radiolucency size. 6 months recall shows more healing. 10 months recall shows almost complete healing. And this is the 3-year recall, shows complete healing. Calcification management. Look how this tooth was completely calcified. I managed to find the mesiobuccal and the palatal canals first. After that, I found the distobuccal canal on a bizarre location. I found the distobuccal canal on the distal marginal ridge. I did a tiny perforation during search, which was repaired later using root PT. And here is the immediate post-obturation and perforation repair using both ST and PT. Hydraulics power. Bioceramics are a real savior and a game changer material. How? Perforation repair. This is a male colleague who came complaining severe pain related to his lower second molar. After I removed the gataperca, I found a tiny perforation in the furcation area. After detection of the mesial canal, here is a confetti X-ray, immediate post-obturation and perforation repair using the sealer, not the body. Here is a 1-year recall. Another large perforation repaired using the body. I did this case 5 years ago. I repaired the perforation using root PT. This is a 4-year recall. The body is still the same, did not wash out, did not resorb, despite the composite at the distal margin was ditched. So the body survived, but the composite didn't. This is a referred case from a colleague for inability to find the mesiobuccal canal and for perforation repair. Here is the file in the perforation site. Here is the perforation site periphery. After removal of the granulation tissue, after detection of the canal, confetti X-ray, and here is the immediate post-obturation, perforation repair, and here is the immediate post-X-ray. The 1.5-year recall, the X-ray on the right is completely healed. External root resorption. This is a case with massive external root resorption related to the distal root of lower first molar. The 6 months recall shows significant reduction in radiolucency size. Okay. Here's a female colleague who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a large radiolucency related to a massive external root resorption related to the distal root. We decided to give the tooth one more chance. Here is a H file and the resorptive defect. I decided to obturate the mesial root first, and I blocked the distal root using Teflon as the canals were oozing blood and exudate. I did the same for the distal, and here is the immediate post repair using the sealer, using only the sealer. And this is how external root resorption may look alike. The 4 months recall showed significant reduction in radiolucency size, and the patient was completely asymptomatic. 8 months recall shows more healing. And here is a conclusion from a study that was comparing different PC sealers worldwide. They found that root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the surface. Day 0, 4 months recall, 8 months recall, 2 years recall shows complete healing. Intentional replantation and the crack management. I did this case in 2013. I did direct pulp capping using calcium hydroxide. Unfortunately, in 2017, signs and symptoms of apical periodontitis started to appear. We did root canal treatment. In 2019, the tooth almost completely healed. Unfortunately, in 2021, a horizontal crack pattern started to appear. I decided to give the tooth one more chance. Here is a methylene blue dye staining the crack line. I filled the whole root canal system using root PT. Unfortunately, the patient still have symptoms, so I extracted the tooth and cut the apical part of post root, then put back again into the socket. And here is the 3 months recall, shows significant reduction in radiolucency size, and the patient was also completely asymptomatic. This is another case of intentional replantation. I wasn't able to retrieve nor bypass the separated instrument in a dilacerated mesiolingual canal of lower second molar, so I extracted the tooth, cut the apical part of post root, then filled using root PT, then put back again into the socket. Lateral canal scouting. During scouting trial for the distal root of lower first molar, a lateral canal was detected, as you see here. This is a lateral canal that was detected. Unfortunately, the file was separated inside the lateral canal. After injection of the sealer penetrated beyond the separated file. Here also, after scouting the distal root, a lateral canal was detected. Again, after a lateral canal was detected and was easily filled with the sealer. Okay. This is our last part. Deep split management for non-microscopic clinicians. This is a Vertucci type 7 upper second premolar, has the anatomy of 1, 2, 1, 2. I'm gonna tell you some tips and tricks to manage such tough anatomy. Number 1, stick to the reference point, buccal cusp, palatal cusp. Number 2, recurve all your instruments, your hand files, your rotary files. Number 3, use of polymer needles, plastic needles for irrigation and activation. Number 4, shape both canals together. What I mean by shaping both canals together. When you start shaping of the buccal canal, using, for instance, 2004 rotary file, you will do the same for the palatal canal. Till you reach your master apical file, in both canals. Because if you shaped one canal to the master apical file and then you started shaping the other canal, every time you put the file to start shaping the unshaped canal, the file will tend to enter to the larger canal. So you will find difficulty to enter to the narrower one. And that's what I meant by shaping both canals together, as a difficulty in this junction, the difficulty in this part, the one which they are connecting again, then splitting back. So you shape both simultaneously. This is another upper first premolar with Vertucci type 7, has the same anatomy. This is a difficult part. Most of the time, when you tend to enter one canal, it will hit on the wall. Again, this is another Vertucci type 7 upper second premolar. This is another difficult splitting buccal and lingual canals. Again, another splitting buccal and lingual. Okay. This is another level of deep splitting. As you see from the preoperative radiograph, there is a one main canal, as you see, and the two tiny splits are obvious in the preoperative radiograph. Are they obvious? Do you see them? Okay. I cannot see the splitting. I just scout to find. Here is one split was detected, one split and the main canal. Here are the two splits were detected. Okay. This is a 4004 rotary file in the main canal. Now, how I will obturate these tiny splits? I cannot see, I cannot fully shape these tiny splits. Okay. I tried to make Getaperca harder by recurving and putting on an ice cube, then sprayed with Endo ice to make it more stiff. But I failed to put these Getaperca cones in the splits. So I decided to depend on another strategy, which is the hydraulics power. I chose the largest Getaperca cone that gives me the toughest tug back. This Getaperca cone here was 4506 Getaperca cone. Then I down bagged the cone till the level of the split. So I blocked the main canal first. After that, I injected the sealer and added the rest of the cone. Here the cone started to push the sealer. There is no escape for the sealer through these tiny splits. And there is also a lateral canal started to appear. Here I added more sealer and I added tapered auxiliaries. Tapered auxiliaries to give more hydraulics to the sealer. Very important this step, you sear off the Getaperca at the orifice level and do some coronal compaction and you're done. This is the immediate post-obturation. You have heavily filled and buffed splits with the sealer. Okay. This is another splitting lower second premolar. During scouting, I found 3 splits in the lower second premolar, sorry. Master apical file. This is bitactile, by the way. I'm not seeing anything. Unfortunately, a rotary file was separated on one of the splits. I tried to bypass. I was able to bypass, but not fully bypass the separated instruments. It's a very, very tough bypass, by the way. Confit X-ray. Here is the immediate post-obturation using Root ST. Look, the sealer was pushed beyond the separated file. So the sealer solved the problem. And this is the immediate post-obturation for both lower first and second premolars. This is another splitting. Look, this is what we call 3D obturation. This is a different X-ray view. As you see, multiple portals of exits were filled with the sealer. This is our last case. This is a case for lower first premolar that was a part of a bridge with multiple splits. During the scouting trial, 2 splits were detected, 3 splits were detected, 4 splits were detected. Master apical file for the splits. You inject your sealer, your master cones, and here is the immediate post-obturation using Root ST in conjunction with Getaperca. And here is a quote from my mentor, Dr. Alan Nasih. If you're always worried about failure, you will never reach out for success. Thank you, ladies and gentlemen. I hope you enjoyed the presentation. Shukran. Shukran. Thank you.
Thank you. Thank you, Dr. Mina, for
Thank you.
insightful seminar.
Thank you.
And thank you for everyone.
Thank you. Thank
you can have the hands-on at the back.
Okay.
And if you have any question, please don't hesitate to reach out to Dr.
عايز اسلم على
Mina.
الدكاتره بس. الله يخليك، اشكرك اشكرك يا دكتوره. عامله ايه؟ كويس يا دكتوره، اخبارك يا باشا؟ ما انا